Well, welcome to the Incarceration Prevention and Reduction Task Force Crisis Stabilization Facility Committee meeting here on April 18th, 2024. Before we begin, I will read the land acknowledgement. Before we begin, we acknowledge that we are gathered on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that brings us together here today, and please join us in uncovering such truths at any and all public events. Well, again, welcome, folks. I truly appreciate the time that you're taking to attend the quarterly Crisis Stabilization Facility Committee meeting. I will call it to order at this point. And the first agenda item is the Ann Deacon Center for Hope quarterly census. Jill, I think I can share my screen.
Yes, you should be able to.
Hopefully folks can see that, and it's large enough to actually read. Don't know if you're aware of it or not, but you can actually slide the attendees over. You have control of that, and you can make the picture a bit larger. I didn't realize that for a while, but you can do that. What I have here is really, I wanted to do a culmination of 2022, 2023, and then the first quarter of 2024 data from the Ann Deacon Center for Hope, just in terms of some comparison and, possibly questions, that sort of thing. I'll orient to you in a little bit if it's a little bit busy. The top part is Pioneer Human Services. They are the provider for our withdrawal management services. The upper section is 2022, then 2023. I did the same thing for Compass Health. They are our provider for mental health stabilization at the facility. This is 2022 and 2023. And then summarize just some information. We're obviously always oriented towards bed utilization and maximizing that. And so I summarize just that information relative to withdrawal management services in 2022. They had a 77% bed utilization. I think that everyone is familiar with the fact that we have 16 beds for withdrawal management services and 16 beds for mental health stabilization. In 2023, they had a pretty similar bed utilization of 4,429 at a 76%. For mental health triage in 23, we had a 56% bed utilization, and in 2023, a 61% bed utilization. I'll jump back up here and we can talk about some of the other pieces, but I also wanted to share the quarter one data for 2024. The bed dates are estimated by virtue of just multiplying 16 times the number of days in the first 3 quarters of the month. That's how we arrive at 1456. Obviously, the utilized beds are the reported beds that are used. Withdrawal management services utilized 1,199 beds at an 82% utilization rate, and obviously the same program bed days for mental health stabilization services at 1,044. They're currently at a 72% bed utilization. I'll stop there for a moment in case there are questions, thoughts.
Yeah, Perry, I got a question.
Sure.
So that, if I'm looking at the bottom columns there, so that's a pretty noticeable increase, at least for the mental health side, which I assume is a good thing. Do you got an idea Is this a trend or is this kind of a one-off?
Well, I can offer my thoughts about that. There's been a number of different things that have occurred during this first quarter. Well, actually starting in the last quarter of 2023 and the first quarter of 2024. And so I'm seeing that as a trend as opposed to a one-off. We've made some efforts. I'll certainly talk about those in more detail to just address the challenges in terms of bed utilization. Great question. Executive Sidhu,
Yeah. Can you hear me okay?
I can.
Okay. When I look at that unduplicated service, in all the columns, you look at that, that is more like, it means that this is like a quarter of that, 25, 30% of that unduplicated. So it means the reverse way, 75% of the people are duplicated, mean the same people served again and again and again.
That is an accurate statement.
Okay, then my second question is, how many of them are which are related to all of these two services, and how many of those are, what are we doing about that to reduce that population? I mean, that it really, these numbers tell us where to focus.
Yes, I would agree. And what we're doing about it is continuing to develop and work with a very important component that, oftentimes isn't talked about relative to the services at the Ann Deacon Center for Hope. And that is the care coordination and ongoing support of individuals that are discharging from the facility. Again, this is my culmination of, thoughts and information about it, but I think that part of this is reflective of the limited resources that we have compared to population relative to behavioral health services in the community. That is one aspect. I don't think that it's necessarily the overriding aspect, but I think that that's one aspect. I think another aspect that we're seeing is the nature of the change in substances that are used by the population. Everybody's obviously, very familiar with, some really extraordinary challenges relative to opioids. I think that an additional component is certainly homelessness. We obviously talk about that a lot, and I think that that's another component. And I think that beyond the services that are offered within the Ann Deacon Center for Hope, the continued work that is happening within the county to develop those resources and address the challenges. Obviously, the recently released executive order, I think, will have an impact on that number of individuals that are returning to services continually. I am certainly struck, as everybody else is, by the extraordinary nature of opioid and methamphetamine dependency and the challenges that occur for individuals that are maybe approach simply the process of withdrawal management services and don't continue on through ongoing inpatient or other levels of care services. So I think that those are primarily the factors that are playing a role here. Of course, that's a very difficult thing to capture as far as the why, of that.
Perry, if I may, I would like to say that if we can kind of dig deeper into this. Now, the other thing comes to my mind is that it may not be the same 50 people or something. It may, and that set of people may be changing. There could be first 50 people, first 3 months where they were duplicated, or 6 months, and then a new set of people start and they get duplicated, but they get lumped up into this thing. So what I'm trying to say is, with the executive order and resource utilization, we are putting a lot of money, and we can put a lot more money. I think this is very eye-opener for us to do little micromanagement on these populations. I mean, we have this multi-million-dollar facility, and we're spending millions of dollars to manage this facility or operate this facility, and we are serving a very limited set of people, right? And what are we? I mean, to me, this would be more utilized if it is like half and half. And I mean, that is our whole purpose, is to bring people who are new to this and provide them services. People who are repeated users, we should do something different with them. So anyways, I will stop here, but that's what inference I draw from here.
And
I think, go ahead.
So that what Sapal's bringing up with the unduplicated. So at the last blue column there for mental health, it's the unduplicated is a pretty high proportion of those referrals. Is that just because it's the first quarter and we get to the fourth quarter, then we'll see that ratio of unduplicated to total referrals?
Yes, you're reading that accurately. Yes, indeed. And it's a great point. I think that some of the other, components that are, also referenced in the executive order, relative to the 23-hour crisis relief center, I think that many of those factors are going to play a role in it. And, I think there's wisdom in the approach that we're taking at this point. But noted in terms of digging deeper into that information, at least the data, and saying, well, where is that happening? And again, going to the providers and talking with them and saying, why do you think that is happening, from your perspective? Because I don't suspect, well, I think that some of the factors are certainly similar between mental health stabilization and for withdrawal management services, but not necessarily, if that makes sense, that the same factors are playing a role there. Other thoughts, comments, questions about the data? I have some other stuff I want to share with it, but I just wanted to stop here.
Well, Perry, Mike here. I'm always concerned about that super low EMS number. That's just always there, and I'm hoping that maybe some of the stuff coming up here in the next few months may help get more EMS, referrals into there. But yeah, it's just more of a comment, Perry, than anything.
Yes, absolutely. And, that's a great point, actually, Mike, that we should stop and talk about just a little bit. And you obviously have more information, more detail about this than I do. But this is really reflecting the community paramedics.
Right.
Predominantly that are working with, if folks will recall, that are oftentimes working with the GRACE team and or, at times certainly the lead team, response systems division in general. But there are some, and you can certainly elaborate on this if you'd like to, Mike, there are some challenges relative to transport to the requirements of transport on EMS's part to the hospital. As opposed to the Ann Deacon Center for Hope. And I think that is somewhat reflected. These are the referrals. Hopefully folks can kind of see this. If you look at PH, that is St. Joe's Hospital, Peace Health. They are a very large referent to both the withdrawal management services, as you can see, as well as the mental health stabilization across the board. And of course, many of those individuals arrive at Peace Health through process and transport with EMS. So I'll offer that. I don't know if you have additional detail.
Yeah, no, you're spot on, Perry. And that's exactly what's going on. Our community paramedics really are only ones that have that a large amount of time to spend with that patient, because they're having to case manage them, into the facility. And so the real issue is that there's no way to do the 15-minute drop off over there because the average EMT paramedic out there working the streets, they're on their daily shift, just doesn't have that kind of time. And, a little bit of loss of confidence with the paramedics, community paramedics, to get them in there as well. And there's no particular fault. I'm not throwing fault here. It's just, it's that whole process of getting a person checked in, making their, these activities of daily living. Are they on CPAP? Are they not? So yeah, what I'm hoping, because we don't see it here, it's hard to tell how many people from EMS went to the hospital from their overdose, and then were they navigated to the Ann Deacon Center with there. So that might be a success that's not seen in the numbers, because yeah, the 40s in the first quarter, 47 people from Peace Health were referred. Well, I know 60% of the EMS engagements for overdose are going to the hospital. The other 40% typically AMA out. And those 40% are the ones that we hope to get maybe in a follow-up. If we get an opioid response team active out there, that 40%, maybe there's a follow-up there where they could do that work to get them into recovery in another direction. But no, you're spot on, Perry. I mean, that's really the challenge of field referral. You need the community paramedics to spend that long amount of time to get them in.
Right. And our relationship, when I say that response systems division and the work with community paramedics is truly amazing, just from my perspective, in terms of that they will attend our response systems division all staff meetings. There is regular communication. I get calls from them at times just navigating systems and so forth, and so I'm more than happy to obviously address that and just appreciate that relationship and their level of skill and sophistication for that matter.
Yeah.
Thanks, Mike.
I will say in those numbers, Perry, there is hope, right? So here in first quarter, there were 2, but if you look in 22 and 23, there were 2 and 1 total for the entire year. So at the very least, if we're tracking 2 or 3 in the first quarter, there's hope that there is more, after the year, we'd have 8 or 9 from EMS that got referred. So that's a better number for first quarter.
I agree, and I think that in part that is the relationship with Grace. Is it mentioned that they work in the field with the Grace team members, and a lot of communication with between Grace and the community paramedics by virtue of involvement with the response system division and my involvement with the crisis stabilization center, and communication and contact and etc. So it's a great point as well. Yes, Peter.
Thanks, Perry. Yeah, I've got a few questions. Let's see, a couple months ago, it seems we had a meeting on the subject of the Ann Deacon Center and brought everybody together. It's, many of the problems that we were addressing are systemic problems that, due to licensure, insurance and such, are not going to be easy fixes. However, there were some low-hanging fruit issues, it seemed to me, that might be fixed relatively easily. And I'm wondering if you could update us on anything that might have changed or happened. Then I am wondering about, because I'm fairly new to looking at these numbers, I'm curious if anything in particular sticks out to you as particularly low or high or particularly interesting. And then my third question is, to Sat Paul's point about the people going around and around, the duplicated served, I guess, are we able to track those individuals? I mean, I presume we know who they are. And are we trying to get them into a GRACE program or a LEAD program, or focus more resources on them in some way? Do we have some sort of mechanism to do that, to improve the situation and see them not come back, hopefully? So anyway, there's a smattering of questions for you.
Yeah, and some great stuff. I definitely have more detail. I'm going to answer them backwards, Peter, and kind of start with your last question. I think that it is important to track these individuals, and I absolutely believe that both Pioneer Human Services and Compass Health are able to do that, so that we can extract some additional information about the demographics, if you will, of those individuals, because I think that that's going to be important. I believe that everybody is aware of the fact that the services are actually paid for to the providers through Medicaid. The county does not pay for these services. The county does offer a what I consider to be a lower rent to be able to subsidize, the services, and et cetera. And I say that for just a couple of reasons. From a confidentiality standpoint, knowing they certainly know the individuals and recognize them and have charts and and that sort of thing. That isn't information that the county is necessarily has access to, specifically in terms of, individuals' names. Although, of course, if the individuals involved in Grace lead the art program co-responder, were cognizant that, individuals have been transported to the Ann Deacon Center for Hope. And so it's a great point. Being able to drill down further into that information, I think will clarify that. And I don't think that the tracking is probably terribly difficult on an individual basis to say, well, who are we? How many readmissions are we talking about? And did the individual leave against staff advice? Well, what are the nature of those? The things that stand out for me are certainly the unduplicated services. I'm feeling really hopeful and positive about the utilized bed date increase. I don't know the number, but I don't believe that it's realistic to expect 100% bed utilization, only because of the discharge and intake process that we're getting towards. If we're up in that 80% area, I think that we are, getting, pretty much to capacity. That's my opinion about that. I can certainly, engage, others about that, but we can, continue to gather that information. The other challenge, of course, and probably a good one, is if we did reach 90%, or better consistently, that one of the things that, of course, will happen is that law enforcement, other first responders and so forth, experience is going to be, I don't really use it because it's full. Those kinds of efforts. I suppose I'd be more than willing to defend that particular challenge, because of obviously the success that's related to that. So that's one of the things that stands out. The other one is I continue to pay attention to the referrals from Peace Health. They've been a good partner. They come to our monthly meetings. They talk about the challenges of communication. At times, the hospital will view an individual as meeting criteria and eligible for a level of care at the Ann Deacon Center for Hope. And there is some professional opinions there, of course, of what they are able to do. And I think that everybody's aware also of the fact that Peace Health, experiences a lot of challenges as far as capacity, and certainly has, that has been a fact, since the opening of the Ann Deacon Center for Hope. So that's a piece that, that certainly stands out for me. I'm thrilled that Base Camp is accessing and utilizing historically Base Camp, the information, sort of anecdotally or just in general communication with the Response System Division, was that the Ann Deacon Center for Hope, the service providers there, were hesitant to admit individuals that were struggling with the challenges that oftentimes individuals that are involved in Base Camp present. And yet what we're seeing is increased numbers of referrals and utilization of the facility. So that's something that stands out to me. I absolutely am going to talk about changes and actions of low-hanging fruit. If I can, I'll come to that particular piece. I know that it's not outlined in our agenda, but I absolutely have the information and want to speak to that. Councilmember Donovan.
Yeah, this is one other piece of information. In our last meeting, we were talking about people getting turned away for substance, whatever, they're too intoxicated, or they've got some health conditions, or potentially it's an insurance thing. Like, if there's a way we could get a sense of trends in that over time, that'd be useful information as well, I think.
Noted. Thank you. One of the things that I will say, and I can't remember, I've talked about this so much, that one of the challenges that was happening, particularly with withdrawal management services, I was contacted by the manager and said, we are running into a lot of situations with individuals that have private insurance that we get the clearance, we'll contact the insurance company and get the, basically you have to get coverage okay for that, for the person to be admitted into a sure payment. And then later, when they submit the invoices, the insurance company responds with, oh, they've met their lifetime cap. They've, various reasons that, the facility didn't get paid. And so the manager was like, boy, I'm feeling like we're going to be sort of cornered into a situation of where we're going to have to no longer accept private insurance, which of course was going to be, a huge challenge. And he was very concerned about that. It's a success story because I made contact with the Behavioral Health Administrative Services Organization. I think folks are familiar with Jan Rose Martin Ottaway is the director there now. She stepped in, we held meetings, and the BHASO assured both Compass Health and Pioneer Human Services that if they have declined payments of services that were provided, that the BHASO does cover that. So it was just a real success, just in regard to that particular one. So we've got that noted, Councilmember Donovan, and we'll continue to, take a look at that. Yes, Peter?
Seems to me until we start tracking individuals, we're never going to resolve these problems because, well, for obvious reasons, I think. And so in my work on the IPR, I'm just constantly bumping up against that. And here I'm kind of wondering, is there any way that we can know what individuals are going to both sides of our crisis center? Do we track that at all?
To my knowledge, that is not tracked. There is a confidentiality issue between the two programs, understandably, but I think that may be something that we may be able to get some help with. I'm brainstorming here, so I won't belabor this, but I think the BHASO may be able to step in as a entity that does have access to the data and the individual's names and could do a comparison with that, for example. So I don't know that it's an insurmountable thing. Linda?
Yeah, I don't know that I have a huge amount that I could add here, but I will say on, so for 2 points, one on the data that the ASO has, some of our data will probably be limited in that we're covering a minority of folks in terms of those who don't have active Medicaid for the most part, or those who are, private insurance, or for whatever reason, they're dropped out of that Medicaid bucket. So in that sense, we may, at least on the withdrawal management side, I can't speak as much to the crisis side, might have some limited data there. As to the confidentiality, just wanting to note and put out there that there have been some very significant changes within the last month to CFR 42 Part 2 that is now much more closely aligned with HIPAA. So that has been a sort of a tidal shift in how communities are interacting and sharing data. So with only a single release of information, not specific as it was to place and time and person. Data can now be shared between entities much more easily. You still have to get the initial ROI, but just noting that that is a kind of significant change that's very recent.
Yeah, thank you so much. And for folks that don't have this information, 42 CFR Part 2 pertains specifically to documentation and confidentiality relative to substance use disorder. And it is a bit more robust, I guess, than historically has been more robust than HIPAA, which everybody, of course, is familiar with. And so just really appreciate that information. Great thoughts, comments, questions here. Again, I have some additional information I'll move on to, but want to make sure that folks get some of the great questions answered that they've been asking. All right, I'll stop sharing here and kind of move into just some kind of other points. Again, forgive me that it's not elaborated on. I consider it to fall under the agenda item that we're currently talking about, although quarterly census. But I wanted to talk about a couple of other pieces. One of the things that we've been paying a lot of attention to relative to the Crisis Stabilization Center is law enforcement use of the Crisis Stabilization Center specifically. And in 2022, we had law enforcement drop-offs in withdrawal management of a total of 19. And in 2023 for withdrawal management, we had a total of 36. So seeing those numbers improving. For mental health stabilization, law enforcement drop-offs in 2022 of 56. And in 2023, it actually totaled 45. So, we're seeing some various utilization by law enforcement in the Crisis Stabilization Center, at this point. And that obviously continues to be a focus, relationships with BPD, as well as the sheriff's office, as well as other law enforcement offices within the county in terms of, that communication, encouraging, the use of the Crisis Stabilization Center, and also a process that both Pioneer Human Services and Compass Health have implemented for streamlining that drop-off. There's actually several components to that, but they reworked their process of essentially breaking the intake for an incoming individual down into components, those that really need to be addressed right up front, and then waiting if there are others, so that law enforcement and first responders aren't held, at the facility to complete that. We also have a direct call-in line for law enforcement first responders. Essentially, what it does is confirms that there is an available bed, and also ask 5 basic questions pretty quick, in terms of that information that they're gathering, just to avoid law enforcement first responders coming to the facility and a determination that the individual is not eligible for one reason or another. That is laid out in, I think everybody's pretty familiar with advisor cards that we produced and distributed to law enforcement. So the questions and the phone number and the process is outlined on the visor cards, because you've got to get that information out, obviously, to the officers and deputies, to be able to encourage them to use that. The other factor that we've ended up addressing that I think was a real factor for law enforcement, the first responders, for the time that they were spending there, was the provider's view that, if you will, that it was the individual that they were transporting was their client. I'm going to use that term, their client, as opposed to, once they arrived at the facility, that they are the responsibility of the provider. They may not be able to admit them because of certification, licensure, things that we've talked about, but that doesn't mean that we need to use law enforcement or first responders for transportation. And so that process continues to move forward. We've worked through in several different ways, ensuring that transportation is available for individuals if they aren't eligible for admission, and that has also reduced that law enforcement first responder time frame that they're there. It's a little bit like a slow moving ship and turning a slow moving ship, because of course the law enforcement first responders that haven't again utilized the facility are holding that and saying, no, it takes too long, for a drop off. I was there however many months ago and it took too long. And so they, of course, understandably hold that, belief system. So I wanted to just touch base on that. Yes, Peter.
I just wanted to note that the SAMHSA best practices document on crisis systems notes that best practice is to have a system wherein law enforcement, EMS are able to, at a glance, computer system, see what beds are available. And so we should obviously be moving towards best practices, and instead of a phone call, I can well imagine that in the near future, developing something of that sort would get us down the road.
Agreed. And there's a couple of things that are happening with that at this point. There is, at least Monday through Friday, there is an email that goes out to Response Systems Division and all of our partners that clarifies the current census, in both of the facilities. And I agree with you. And Mr. Hilly has brought up, the same. There are some systems obviously in place with a dashboard, if you will, that first responders can go to. And I think that it is important. I'll admit that part of it has been, well, right now we always have a bed. Because our historically, our bed utilization wasn't at a level that it's like there's a 95% chance that there's an open bed. We even talked about the possibility of keeping a bed open, which I sort of shot down, for the very purpose of, well, if it was law enforcement and so forth. At least at that stage of the game, I'm like, okay, wait, we're not gonna make the utilization 15 beds instead of 16 at this point. That's not the best approach to that particular situation. But I agree with you. A quick dashboard reference, that's online, easiest and quickest way. Obviously, maintaining current and updated information, super important, because it changes, throughout the day, and some of those particular challenges. So yes, other thoughts and comments about that streamlined drop off?
Well, I just agree, Peter. But we've talked about that a good bit, about how could that be held in dispatch, right? Watcom, for example, they just have that up on a screen. I don't know if you've been in there, that multiple screens, multiple cameras, and could that just be something that's just sitting on a screen somewhere? Even if it changes during the day, you would just see that number and that availability. But it doesn't negate the original problem. Even if it got the beds, the original problem of having to spend all that time to figure out how to get them in, the
Yeah,
facility. So that's been the other
Yeah.
piece. I will say, from a more global sort of perspective, in the state, there's a organization. It's called the Northwest Healthcare Network, and they manage a website called WATRAC. And WATRAC has the ability to go in and look at every single hospital in the state to understand how many beds are available, say for trauma, for cardiac, et cetera. And it's used primarily during a mass casualty type of thing. So there has been some conversation in that, could WATRAC take on the bed availability for mental health and substance use disorder facilities around the state? So if we were full and we needed to get somebody in, you'd be able to go on WATRAC and go, oh, I see Chehalis has 3 beds open, or I see there's 3 beds in Mount Vernon or Yakima. And maybe because some patients have to go out of the area to get long-term inpatient. So could that be a place where that might happen as well? So under the opioid crisis, that might be a strategy for the governor if they actually get into an executive order like we're doing here locally. I don't know.
That's really good to know about. I saw that other professionals column, Perry. Could you explain who the other professionals are, and whether they need this information that we're talking about? That if there's a fair number of referrals from other professionals, and do they need to know who, how many beds are open, and would they be calling 911? So how would they know?
Right. So I think really two comments to add to what Mike was talking about. I think that folks are aware of the fact that we actually have a response systems division staff that is embedded in Whatcom. And so it's a great point because as that information is there, we also have, an individual is well educated in terms of, the response systems and crisis systems and can communicate that with the other dispatchers that are there. So I think that that's a really viable thought process and idea. I'll claim it for my own when I talk to my boss and say, I've got this great idea, et cetera. But anyway, the number of other professionals is essentially substance disorder professionals, behavioral health clinicians, case managers, et cetera, that are aware of the facility. And again, I'm biased because I'm one of those, but I will say that they are more familiar with getting individuals or familiar. They're more they very commonly will do this process on almost a weekly basis of getting an individual referred to a facility such as the Ann Deacon Center for Hope. And so they have relationships, with those entities. They will call, work that through. They're already prepared to answer the information because, again, they've done it, multiple times because of the nature of the work that they end up doing. And so it really is a catch-all bucket for any other professional that might, beyond first responders that might, refer an individual. And we try and separate that from just families, the individuals themselves calling the facility, et cetera, and asking for, admission. And those are, those numbers are pretty significant. So hopefully I answered that question for you. All right, I'd like to touch briefly on 12-hour law enforcement holds. Again, just a little bit of a background. There is actually an RCW that allows for a crisis stabilization center licensed certified at the level that this is, that an individual that has committed a low-level crime that is in likely need of services, at the withdrawal management services or mental health stabilization, that law enforcement actually has the option of transporting the individual to the facility and placing, if you will, a 12-hour hold on the person. Essentially, the description of this is really that law enforcement is describing for the individual that, hey, we've made an agreement here that I'm going to take you and get you admitted in the crisis stabilization center as opposed to going to jail. You're in agreement with that. You need to understand that the agreement is that you're going to remain here for a 12-hour period of time. We hope you stay longer, and the staff is certainly going to encourage you to do that. But at a bare minimum, you have a requirement of remaining here for a 12-hour period of time. And that's essentially describes, if you will, the language in the RCW, the related RCW. This has run into some challenges. I'm sorry to say, because we've been talking about this really since the inception in IPRTF of the Ann Deacon Center for Hope. Compass Health is the entity that actually by RCW is allowed to do this. They have gotten additional certification to allow this to occur. Through Department of Health. They've actually hired and trained staff required by that certification in order to accept 12-hour law enforcement holds, but ran into a bit of a challenge in working with the part of the RCW. Again, sorry, this is fairly sophisticated, but part of the RCW requires the prosecutor's office to be involved, essentially to identify what crimes could be considered in involving a 12-hour hold, and the concern that I think everybody is aware that the Ann Deacon Center for Hope is a voluntary facility. It is not a locked facility. And law enforcement and the prosecutor's office were concerned that, well, if it's not a locked facility, the individual is simply going to walk out the door. or has the potential of walking out the door. And then there are liability issues that come from that. I took an individual that could have been, taken to the jail. Instead, we chose the Crisis Stabilization Center. The individual left, committed additional crime, hurt somebody, etc. So the liability concern, existed there. And so, it's a bit of a challenge. It actually, when I met with the prosecutor's office and had this discussion, they turned it over specifically to the attorneys that are involved in liability and etc. I had a brief touch base with that attorney. He understandably informed me that his client was actually the sheriff's office in this particular situation, and that he couldn't share the detail of that discussion with me, but was communicating with the sheriff's office, at that point in time relative to the liability and the recommendations and so forth. All of that being said, I tend to trust the process. I push back. I ask questions and etc. But I tend to trust the process. That since that period of time, we do have a new sheriff, as folks are aware of. I actually have a meeting with Sheriff Tanksley here in May. Certainly wanted to discuss this further because, from my perspective, anyway, he's very interested in utilizing the resources and getting individuals to the right place. That's my perspective. There may be barriers that he's not able to, necessarily address. And so those discussions are going on, but I would like, we haven't ever done a 12-hour law enforcement hold at this point in time. One of the things that also is a part of this RCW 1031-110 is that if the individual does leave, the provider is responsible to make contact with that office, whether BPD or the sheriff's office, and inform them immediately that the individual has left. Obviously, they're going to employ motivational interviewing and multiple efforts to keep the individual engaged. But if the individual wants to leave, there is no opportunity for the staff under the licensure to go hands-on with the individual. They cannot detain the individual unless it fell into a process of imminent risk and danger. I think everybody's familiar with the ITA, the involuntary treatment admission process. If they don't meet that criteria, then that's not an option. Yes, Steve?
Hi, good morning, everybody. I just comment that yes, that is correct. Sheriff Tanksley is interested in utilizing this. I was trying to find the text message function on here, but I can't find it. But really, the advice that we got from the prosecuting attorney's office as our legal counsel is not specific to what I think you're talking about. And I can't, it's subparagraph 3. You guys can look it up on your own, but I can read it. It says, in deciding whether to refer the individual to treatment under this section, the police officer must be guided by local law enforcement diversion guidelines for behavioral health developed and mutually agreed upon with the prosecuting authority, with an opportunity for consultation and comment by the defense bar and disability community. These guidelines must address at a minimum the length, seriousness, the recency of the known criminal history of the individual, the mental health history of the individual, if available, the substance use disorder history of the individual, if available, the opinions of a mental health professional, the opinions of a substance use disorder professional, and it goes on and on. Anyway, what we would need is an agreement with the parties to actually be able to utilize it. So whether or not the sheriff's office has liability in utilizing it is different from having these agreements in place to be able to use it at all, irrespective of whether it's liability on the sheriff's office itself. So I hope that clarifies what our position is.
Really appreciate that, Under Sheriff Harris, because that's new information. I mean, some of it is language that's also included in this RCW 10 that I had made reference to, but that's more information than I had. I wanted to respect, obviously, the confidentiality and relationship with the county attorney and the sheriff's office, and really trust that process. because I do want to also say in regards to the co-responder program and other involvement and so forth with the sheriff's office and response systems division, the collaboration and work has been extraordinary, and I think extremely beneficial to the community. So just want to clarify that it was not the intent to cast aspersions on the sheriff's office, in this regard. It's a barrier, and maybe if you would be willing, Under Sheriff Harris, would you mind emailing me? I can send you my email address if you don't have it. Just what you had just shared there, because that allows me obviously to speak more in detail with Sheriff Tanksley, and yourself about this.
Sure, and I thought that there was a text message on Zoom, but there's not. It's literally, it's 10.31.110, what you mentioned, it's subparagraph 3.
Okay.
Is what I read.
Yep.
So it's the guidelines as to when we can actually utilize that, irrespective of whether it's a lockdown facility, if it meets the statutory guidelines. The piece that you were discussing about liability is if we utilize the facility and then the person walks away, what would that liability look like for us as a sheriff's office without immunity, versus this subparagraph 3 is whether or not we can even utilize it at all.
Right. Yep. So helpful.
And I didn't take any dispersion on us at all, by the way. That's fine.
Good. Well, we don't know each other, so no way for me to know that. I appreciate that. Thank you. Peter?
In planning for the 23-hour facility, that facility will have the ability to properly hold people, I presume.
The Washington Administrative Code is continuing to be developed, much to my frustration. That's by the state. There's legislative language that says you will, kind of piece with that. And in the event that an individual is an imminent risk to themselves or others, yes, they can be detained at that facility with the intent of bringing in a designated crisis responder to actually complete the evaluation for potential, ITA and et cetera. The designs thus far, and I could chat about this just a little bit towards the end of our meeting, is that we are in hopes of actually having DCRs officed at the 23-hour crisis relief center. So they are immediately available and can, complete that evaluation, because I worry a little bit about detaining individuals. There's, as you can imagine, fairly extensive requirements, in that regard when detaining an individual, and what can and cannot be done, and the licensure and et cetera. That hasn't been fleshed out in by the state relative to the applicable RCWs and Washington Administrative Code as yet. But a lot of questions came up about that because it was written in the legislative language, in that regard. So I think that's important. I also don't want the community to view it as a facility that will detain individuals as a regular practice, because that may be of great concern, obviously, to individuals considering utilization of the facility. Boy, they may detain you. So, don't go there, kind of, concern. So some great questions and discussions. Again, not a lot of additional information, just relative to the 12-hour law enforcement holds, but wanted to touch base on that. Before talking about the 23-hour crisis relief center and just giving a little bit of an update in that regard, and I can, well, I mean, it's recorded, so I suppose that folks have this, but I wanted to also touch base on, Peter, your question just related to our meeting with the Behavioral Health Subcommittee and the providers, of where some really important information was shared, back and forth. And this is certainly in response to that. Some of this activity was happening prior to that, but that also, I think, one of the important things from my perspective of the providers attending the Behavioral Health Subcommittee and doing some sharing and so forth was really sort of bringing them online first person to, this is what we're talking about. This is what the concerns are. These are the things that we need to change. And I've seen some significant response to that. So my title here in what I'm sharing with you is really the relationship development with Whatcom Community Health, Whatcom Health and Community Services, Response Systems Division particularly, and the Crisis Stabilization Center providers, again, Compass Health and Pioneer Human Services. We communicate with both Pioneer Human Services and Compass Health weekly, multiple times on various topics, but have set aside periods of time to meet and talk about plans and actions and get very specific about those things with timelines and and that sort of piece. We've actually completed 2 meetings up to this point in time, and I'll just sort of run down through some of the components of that and then answer any questions that folks might have. I think I mentioned the providers are emailing the current census each weekday at this point in time, and then that is also distributed out to our partners, which includes the sheriff's office, BPD, fire, etc., on an email regularly. Obviously, the providers are submitting monthly census data based on referrals, admissions, discharges, so forth. There is direct contact with both of the managers regarding declined admissions. If there is a concern that an individual was brought, the individual didn't meet eligibility, understanding and having direct contact with the managers of both Pioneer Human Services and Compass Health to understand that more and to avoid unnecessary situations of where individuals are declined admission. And so I've really appreciated that. We've recently, boy, I'd have to take a guess here, probably 4 months ago, maybe a bit more. We have a new clinical manager overseeing Compass Health program. Elise Simmons was the previous manager, and I appreciated Elise's efforts and energy. Renee Reese is the new clinical nurse manager, and I am very hopeful about what I've seen in her willingness to roll up her sleeves, work in some of the nitty-gritty and some of the challenges, because we've overcome some historic challenges that we really struggled with, and so we're seeing some forward movement there. We have a monthly crisis systems oversight committee meeting, and several of the individuals that are in attendance here also attend that monthly meeting. It includes law enforcement, EMS, fire, the providers, obviously, mobile crisis outreach team, Volunteers of America, the PAC teams, Peace Health, and of course, Response Systems Division. And it gives us an opportunity to do several things to really talk candidly about specific challenges that may have occurred in the last month. And also, I think that I've mentioned we have an online systems improvement form that really anybody can complete, but we very much encourage, of course, all of those entities that I listed to be able to complete it, because it brings us a specific incident, oftentimes the names of the staff. We don't really have to have the client's name. We just know the date, and age of the client, which is not a breach of confidentiality. And it also allows us to track the systems improvement concerns and successes for both of the providers. What happens is when a systems improvement form is submitted online, it comes to my email as well as my manager's email. I will typically make contact with the individual that had submitted that systems improvement form, maybe gather some additional information or just understand some kind of components of that, and also share my appreciation for the fact that they took the time to fill it out. And then I reach out and forward that to the manager of the appropriate provider, whether that be Pioneer Human Services or Compass Health. And then I have a discussion with them. Following that, I actually encourage them to reach out to the individual that had provided the systems improvement form and have a direct line of communication and any problem solving that can occur there. So I found those to be super helpful. Before, what ended up happening is I would get an email or a phone call with an array of information. Sometimes it didn't have a lot of accuracy to it. Sometimes it did. But I determined pretty quickly that what was necessary was really to have more detail in regards to that form. Yeah, Peter.
So I just want to understand what I think you're saying. You have a process for getting frontline workers thoughts on system level improvements. Is that if I misunderstood, please forgive me, but
Yeah, no, I think it's actually fairly accurate. I have gotten systems improvement forms from paramedics, from law enforcement, from even response systems division, whether it's a GRACE team member that, you know, attempted to get an individual admitted and struggled with something or didn't understand something, and you know, and others. So
Yeah.
that's an accurate statement.
Can you give me an idea of scale and also how you encourage getting people to reach out with their thoughts about systemic improvements? This is one of the things that we're doing a lot of thinking about in IPR leadership, is how to deal with the L6 problem, the level 6 problems. We're here at level 1 making policy decisions. Level 6, frontline workers. There's always got to be a process for getting that feedback up the chain, because the real wisdom is often down here, and they're dealing with the and I've been doing these interviews myself. Really see there's a significant issue with lack of that information going up the chain to help in policy. So I'm really on all ears.
Sure, absolutely. And so, Peter, if you Google, I mean, I can send it to you, of course, as well. But if you Google Whatcom County Systems Improvement Form, it'll take you to the Whatcom County website, and then the form's pretty self-explanatory in terms of, hey, whatever information you want to share, please don't breach confidentiality. And then, you know, asks about the incident and you know, the other detail that, you know, obviously you can take a look at. I don't have detailed information on the number of systems improvement forms and the nature of those forms in front of me, but I save all of them. And of course, they're also saved, you know, within this system. And we have ended up addressing, one of the things that I didn't make reference to was during the monthly Crisis Systems Oversight Committee meeting, we actually speak to those. Hey, we got 2 systems improvement forms. They, you know, were related to, you know, and et cetera. And the managers are also prepared to, you know, to speak to that and to respond to it. And what I've continued to and have gotten is, so what actions are you going to take, or do you recommend as a manager, as you have seen this, you know, information, whether that might be training or, you know, you can imagine the kinds of things that they're making. And of course, anyone else in the meeting can also suggest, hey, I think that it'd be beneficial to, you know, et cetera. So we have very regular contact about that. I think it's been a pretty successful approach, you know, because again, have somebody email me and say, boy, I tried to get Perry admitted to the Crisis Stabilization Center and it was just a mess. And so I'll call out there and they say, no, we actually admitted Perry. Well, I don't know what to do with that at that point, because somewhere there's a disconnect. But I agree with you in terms of the level 6 to level 1, a lot of important information and the steps in between, in my opinion. Because it's one thing to say, and both the managers have said, I'm right here, here's my cell phone number, you can call me directly, which is fine, but that leaves out the information of us tracking it if that's the way that those are addressed. I think it's a fine, you know, way of addressing it, but of course with, you know, quantity and numbers and so forth, that won't, you know, necessarily suffice. It's a great relationship builder, but, you know, it has its drawbacks as well. Other things that you know, we've implemented, obviously I mentioned the visor cards. I really like the visor cards. I've gone to BPD and the sheriff's office and just done a little dog and pony show about how to use them, and about the Crisis Stabilization Center, about our interest in engaging first responders and law enforcement, our understanding of the time, issues, et cetera. And, I'm more than willing to continue that kind of communication at muster, or wherever it might happen to be, for those. There's a lot of officers and deputies. And so, that same issue of level 6 to level 1, that if level 1 is making the decision, I'm not going to use it, but not communicating that with any of the other levels, well, then we've been stymied at that particular point. As I mentioned, we have bi-monthly Response Systems Division Crisis Stabilization Center provider meetings. And really quickly, so that I can give some time for, additional questions and so forth, I'll sort of rattle off, here's what's beginning to form, and we're sort of narrowing down. Here's some examples of that. Engagement of the BHASO, as I had mentioned, in addressing revenue challenges. Jen Rose Ottaway was amazing in her response and timeliness to that, because it was totally unacceptable for me for a provider to say we won't accept private insurance. That would have been a catastrophe, but yet they need to get paid, of course. And so it was super helpful. Providers committing to developing presentations for the IPRTF. Great to be invited to it, but I encouraged the proactive aspect of, you need to be preparing presentations for county council, for IPRTF, for the city council, et cetera. They need to know what's going on, and you're the best individuals to be able to present that information and the challenges. They both agreed to that. RSD updating providers, as I mentioned, on a weekday basis, relative to census and et cetera. The provision of transportation, flex funds and transportation, just to avoid law enforcement or first responders being viewed as transport, obviously. Trauma-informed care training is an evidence-based practice, as everyone knows. I think that everybody is cognizant of the fact that at times, individuals that utilize the Crisis Stabilization Center can be pretty challenging in terms of attitude and et cetera. That can be based on a whole lot of things, fear and trauma and et cetera. But really working with both Compass Health and Pioneer Human Services relative to the staff being trauma informed. And that means very specific things. I think maybe both of you guys probably know that, but in essence, and we haven't gone as far as, although we will, haven't gone as far as saying, and we will pay for that training, because that's actually an expectation of a any provider that is working at this point in time. But at any rate, trauma informed care and training, because some of the systems improvement forms that we see that come in have to do with staff interaction with individuals, and again, that's sort of self-report and so forth, but trauma-informed care is going to improve that interaction. And as we were talking about the length of stay and possibly, that whole piece of unduplicated, or if you will, duplicated individuals. We've also talked about creating a specific intake time. One of the things that we run into, the licensure and et cetera require the intake, part of the intake process, which can be somewhat lengthy, to occur via a nurse. Obviously, the nursing staff is somewhat limited, just driven by the reimbursement rates and so forth. So if the nurse is already engaged in a intake, they are not available for someone else that is coming in for intake, and that has created some challenges. So talking about creating some specific intake times so that first responders and other utilizers of the facility are aware of that. We have some other thoughts as well to be able to address that piece, but we've seen that be a barrier before of an individual calls. They may be homeless, for example, Response Systems Division, Grace or Lead are helping them, and the provider is saying, we're doing an intake currently, can the person come out in an hour? And we all know that the timing is absolutely essential. If the individual is willing to go to the crisis stabilization center at that point, they may not be willing to in an hour. And so, addressing that. Don't know if folks are aware of it or not, but at this point in time, and actually historically, the lobby of the previous triage facility that, was over in the 2028 Division Street building, as well as this lobby, is actually locked. We don't have any security for the provider staff. And so the lobby historically and was actually designed with a communication system. There's somebody sitting in the front lobby, obviously, that can open the door, electronically and etc. But basically, sort of, ascertaining kind of what's happening, what's going on. Is this a safe process to allow the person to make contact with the staff that needs to work with the individual for intake, answering questions, etc. But we have the goal of opening the lobby. There are some challenges with that, like I said, with security and so forth. So we're working through some of those, but that's one of the action plans as well. We also have been in discussion about consideration of creating a county-funded position as a coordinator at the Crisis Stabilization Center to be broadened to, ultimately, our goal is to have a behavioral health campus, obviously the 23-hour crisis relief center and those kinds of things. And we're really taking a look at the possibility of having county staff be a coordinator on site at the facility, greeting individuals coming in, working through challenges and having a direct line of communication with myself, Melora, et cetera, in terms of, challenges that occur as a component of opening the lobby. Our thought, there was again, sort of safety security issues and a variety of things. And it's like, well, maybe what we need to do is expand staffing. So we're investigating, the possibility of that and those resources. To, again, I think that it would have an effect on diminishing declined admissions, also conceivably diminishing individuals. My term is AMA, if you're not familiar, leaving against staff advice before a recommended discharge, those kinds of things. So those, I know I really rattled through those, but I wanted to give folks a flavor for the work that we are doing directly with the providers. And I believe that in part, the numbers that we're seeing in terms of utilized bed days is a result of that. And also the result of other, components. I don't think exclusively, but that's my opinion. I don't have proof, but I'll argue it forever anyway. Kind of thing. Thoughts, comments, questions. That was a ton of information. It's obviously recorded, so you could, look back over the detail again, but just an outline of, what's happening with them as well. The other thing that I'm kind of excited about, I think that folks are familiar with Dijwalik Wellness Center, the services that they provide. I went and did a tour with a number of other individuals. This was a little while back, and I was really, really struck by the trauma-informed care training and presentation that the entire staff, from security through custodians, presented when I was there. I pulled up to the facility. I was a little bit early. I backed my car in and sat there and looked through emails that I needed to return and so forth. And one of the security staff started walking out towards me, and it's like, uh-oh, I mean, he had security on, and everything. And I was like, oh, geez, maybe I'm parking in the wrong spot. I wasn't really sure. But I rolled down my window and he said, are you here for the tour? And I said, do I look like I'm here for the tour? And he said, well, you kind of do. And I said, well, you're accurate. I am. And he said, well, can I walk you in? Now, I found myself going, okay, did everybody get all primed for, we're going to have a visit from Whatcom County and et cetera, et cetera. And is this, a little bit of, kind of hyper, or whatever. And possibly, although young man was, very nice and so forth. But every office and entity that I talked to was like that. That is engaging, asking questions, offering information, and interested in engaging individuals. We've been working quite a bit with the Dwalik Wellness Center, so I'm arranging for a tour of Dwalik Wellness Center, and they have agreed to it for both Pioneer Human Services and for Compass Health separately and their teams to see what a well-trained trauma-informed care program looks like. Because truly, the Dwalik Wellness Center, in my opinion, and I've been in quite a few facilities, was extraordinary. And if I could transplant that to all of our facilities, I would. So I'm going to make an attempt to do that. So anyway, that's one more step of what we're doing. I'm going to move to 23-hour crisis relief center super quick. I think that folks are pretty aware of that. There's quite a bit of work going on. Just a general overview. This is going to be a 23-hour, 59-minute outpatient setting, and that's why we can have more than 16 individuals. Inpatient IMD rule from Medicaid will not allow facilities larger than 16 in an inpatient setting. This is considered an outpatient setting. Therefore, we have the opportunity to have a capacity of well, a capacity that's beyond 16. It's open 24 hours a day, obviously 7 days a week, and offers adult access to mental health and substance use care for 23 hours and 59 minutes. If the individual is in need of, obviously there's care coordination of getting an individual possibly to the crisis stabilization center or other services they need. That's highly accented in terms of the services that are going to be provided. But if the individual left, somebody asked, if they left for 30 minutes and then came back, would they be readmitted? And yes, they would, particularly if there was additional care coordination work to do. As a matter of fact, there's even allowances within the legislative language right now that says that you don't have to actually discharge the individual if there's an imminent care coordination process that is happening. So you don't have to go by the numbers. You can, do what is needed in that particular situation. The facility will accept all behavioral health crisis walk-ins, drop-offs from first responders, law enforcement, and individuals that are referred through the 988 system, regardless of their behavioral health acuity and without requirement of medical clearance. So nothing of that nature. The only thing that would potentially stop an individual from being admitted would be a severe and significant primary health issue that was putting them at risk at that moment, and they would be transported to the hospital.
Harry, backing up a second on what you're just saying about so if somebody is there for 24 hours and 59 minutes, but they have a care plan being worked out, they can stay longer?
Yeah, let's say that there's an admission to an inpatient, facility, and we need transportation, and the transportation's not there yet. They wouldn't discharge them at that point because the 23 hours and 59 minutes is up.
Okay,
yeah. So
then if somebody didn't have something like that in the works, would they have to leave after? I mean, they can leave at 23 hours and then come back 1 hour later or 1 minute later, or need we do all the paperwork again, or does it kind of seamless come back in?
Right. Nope. Potentially, absolutely. We wouldn't do the paperwork again because it's going to be electronic medical record, if you will. So we're going to be able to retain that information. And again, if an individual just didn't have a place to be and was accepting no services whatsoever, we're going to use motivational interviewing to work with that, individual to say, hey, would you be willing to go over and look at the crisis stabilization center, and talk with the people, that are doing withdrawal management services? Would that be okay? I mean, you can break it down into pieces of where, the individual might be more willing. Oftentimes, interestingly enough, even as an old outpatient SUD provider, fear is what stops a lot of people from coming because they think we're going to do shock therapy on them or something. And it's crazy, but oftentimes fear was the thing that actually stopped them from coming in. So potentially a lot of people had asked, well, so regardless of what's going on, they're out the door, we escort them out in 23 hour and 59 minutes. And it's like, well, no, I mean, if there was an action plan in place that needed to be concluded for the person to be successful, there's a latitude to be able to do that. Initial work for the building site is at the behavioral health campus on Division Street. I think that folks are familiar with that. East of the work center is kind of the location that's been laid out for that. Facilities is working on the multitude of steps necessary to bring that to fruition. Essentially, the 23-hour crisis relief center is made up of a multidisciplinary team. Essentially, this hasn't been ratified yet, but in the legislative language, mental health professionals, SUD professionals, a primary health care provider. Oftentimes, of course, is going to be ARNP nurses. There's also a recommendation of using peers, which I think is a great idea. There's suicidal risk assessment, that is done typically by mental health professionals. Obviously, a needs assessment as the individual comes in of, what are you needing, and et cetera. And then a strong influence relative to the continuing care coordination. That is the discharge. Where are we discharging to? It's not, hopefully it's not to the street, but we connect you back with resources. Oftentimes in the crisis stabilization center, for example, the individual has lost or had their medication stolen, and they don't know how to, get it re-prescribed. So that's one example of, it's like, we can do that for you. Whether it's through the physician, or prescriber that's there, or getting them reconnected to their prescriber, and getting the medication that way. Oftentimes a really important intervention in the, in the individual's process. Cost estimates, this isn't really my area of expertise, but about 12.3 million. Right now, behavioral health fund is going to be used for $1 million of that. Washington State, I think that folks are aware through legislation, about 9 million, and then community priorities fund about 2.3 million. So a total of 12.3 million is the estimate in the building itself. I'm more of an operational guy. And so my interest is, what will that team look like, and et cetera. I mean, I love the people that are building the building and figuring out all the costs and, and that sort of thing. And I tend to be more oriented towards this. Joe Valentine was the historic director of the BHASO. Very knowledgeable individual, and really plugged into legislation and the developing Washington administrative code that relates to behavioral health services. And so the county has actually contracted with him to do some project work around what we think predominantly the operational aspect will look like. So that's been a real benefit for us. Eric Chambers is a staff that works with Health and Community Services, and he is putting together an RFP for provider, using that information and et cetera for providers. Our interest is in getting provider input relative to actually the facility design. And also we've virtually anyway visited existing 23-hour crisis relief centers. There are some in Arizona. There's one actually being developed in King County, and there's also one in Lane County, Oregon, in Eugene. And so a lot of, individuals that we're connecting to and development of, that particular process. I happen to be a little more involved in the operational aspect, but agreed in my role to bring this information to the quarterly meeting. And I used up almost all of the meeting time, and I know that we need to talk about also the committee function and process. Peter, I apologize.
Yeah, we have 4 minutes, so I'm going to, I think I'm going to write an email to y'all and solicit your feedback that way. There's simply no time to do what I was hoping to do.
Yep.
But I appreciate, Perry, all the good information, and I don't think you really have time to address this, but it's going to be a long time before this 23-hour center is up and going, and we have a crisis on our hands. I'm really hoping that there are discussions for moving forward with the very services that we would be getting from that facility before that time. So, I'd love to hear about that next time, perhaps.
Absolutely. And an email, that'd be just great, Peter. Certainly will respond to that. I also have been working quite a bit on some detail with the best practices toolkit, the SAMHSA best practices toolkit, in hopes
Good.
of having an additional conversation with you, and just wanted to kind of provide some technical information to that as well. There is actually discussion, and I think will be fruition of a receiving center that is oriented towards individuals that experience overdose but are unwilling to go to the hospital, and or the Crisis Stabilization Center for Withdrawal Management Services, possibly being located out there at the building that is next to the work center. And there's a lot of interest and energy there. I don't know how much detail I can speak to, in this, but it is absolutely believed. And Mr. Hilley's actually been a part of saying, we need something sooner than 5 years from now, kind of message. And of course, it's absolutely accurate. So spot on. I'm going to have to get more realistic with the amount of information that I share during the quarterly meeting. So, I can send a memo maybe, or something of that nature. Jill, we may have public comment. I'll turn it over to you.
Thank you. We have one attendee today. If you'd like to speak to the committee, please virtually raise your hands now. And no hands are raised. Thank you.
Sounds like she said no hands were raised.
Yes, that's correct. No hands are raised.
Thank you, Jill. Again, thanks for staying for the duration. I know that everybody is really busy. This is something that I'm pretty passionate about. And so I appreciate the opportunity to talk about it. Email me if you have additional questions or anything of that nature. I'll be more than happy to respond.
Sarah, can you adjourn the meeting?
Thank you.
I'm going to adjourn the meeting. Yes, ma'am. Thank you.
Thank you.